Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, I have Craniopharyngioma, Now What, is presented by Dr. Zenonas and Dr. Fazeli. Please hold, as there will be a brief delay while we change presenters.
Excellent.
Perfect.
Can we see the screen okay?
Yep.
All right, perfect. Well, thank you very much for the introduction and for the opportunity to discuss some of the aspects of the diagnosis of craniopharyngioma and what it means for every patient. I'm joined today by Dr. Fazeli, who is our Director of Neuroendocrinology, and she will unpack some of the ramifications of having a craniopharyngioma and living with it, and what does it mean from a hormonal standpoint, which is one of the main aspects of living with a craniopharyngioma. I'm George Zenonas. I'm one of the neurosurgeons that specialize in skull-based surgery at the University of Pittsburgh. We tend to treat a good number of patients with craniopharyngioma, and we thought it would be a good idea to try and sort of delineate what are the series of events that follow after the diagnosis. So our educational goals today is really to understand some of the basics about the disease process that's called craniopharyngioma, and become familiar with the treatment options and the rationale for treating each one. And when do we need to do surgery? When do we need to do radiation? What are the effects of them? If we need to do them, are there targeted therapies, etc.? But also to appreciate the implication of these diagnoses to one's life. So before we go into specifics of the craniopharyngioma itself, we're obviously in the pituitary network. Craniopharyngiomas are tumors that are intimately associated with the pituitary gland. And I'm sure most of our listeners are already quite familiar with this, but the pituitary gland is this very little gland that sits on the base of the brain. It's in the base of the skull, and on top of these natural apertures that we have, the sinuses, the nasal sinuses, and is essentially the conductor of the orchestra. I say here the harmonic orchestra. So it pretty much guides and navigates the secretion of pretty much the majority of the hormones in the body, and has effects throughout the body. Despite its small size, is just so important. So craniopharyngiomas affect the pituitary gland, but also the environs of the pituitary gland, and it's useful to analyze a little bit everything here, just so that we understand that the goal of this is not to be an anatomy lesson, but just to understand how everything is connected and what surgery means and what everything is, what the implications of everything is. So again, we spoke that the pituitary gland sits right on top of our natural apertures of the nose, what we call the sinuses, and specifically the sphenoid sinus. And the pituitary gland, again, has a lot of functions. It secretes all the hormones. So the tumors that affect it can have implications and in the functions of the sex hormones, and Dr. Fazeli is going to speak extensively to it, so I'm not going to spend too much time. But also the function of the steroids in our body that may allow us to feel okay or not and fight disease, our ability to grow, especially in children, that's extremely important, and also the fluid balance. Now, the pituitary is connected to the brain with this area that's called the hypothalamus. It's not that important what it's called, but it is also an area that's very intimately associated with this tumor that it's called a craniopharyngioma. And this is also a very important area that is involved with homeostasis of the body. It controls our appetite, the satiety centers, it controls our sleep and the sleep-wake cycles, our temperature, and it also, it's kind of one level higher up of the pituitary gland, and it guides the pituitary gland how to guide the hormones. And also it's important for our fluid balance. Craniopharyngiomas usually arise somewhere in between the pituitary gland and this area that's called the hypothalamus. So they do affect both very much. Other things that can be affected by these tumors are the optic nerves. These are the nerves that allow us to see. So the majority of patients that will present with a craniopharyngioma will have either an issue with the hormones, or usually the most common thing that they will have is actually troubles with vision. A little bit higher up, we'll also have what we call our limbic pathways. And these are pathways that have to do with emotion, memory, and personality. So personality changes may be relevant in patients that have a craniopharyngioma. And also the fluid space of the brain. So when these tumors become quite large, they can block the spinal fluid pathways. As you know, the brain is swimming in this fluid that's called the spinal fluid, and it has some fluid spaces within it. And this is produced every day and reabsorbed, but it has to flow within it in order to do its whole circle. So when a tumor grows, such as this tumor, the craniopharyngiomas, they can block these pathways, and this backup of fluid can increase the pressure in the brain, causing headaches. It can also cause nausea, vomiting, and also, again, personality changes or even drowsiness. So the majority of the patients that are going to have a craniopharyngioma are going to have one of these symptoms. Occasionally, we'll have patients that have had, let's say, an accident, or they had a scan for some other reason, and a craniopharyngioma was picked up incidentally. And how this presented plays a huge role in what do we do afterwards. And we'll go a little bit more into that in some of the subsequent slides. So one of the most common questions when I see a patient with a craniopharyngioma is like, Doc, how did this happen? Did I do anything wrong? Did I eat anything? Was I exposed to radiation? Do I have some sort of a genetic syndrome? Do I have to get checked in terms of genetics, or do my kids and family need to be checked? And the answer to most of the above is no. These tumors come from essentially trapping of a little area of the roof of our mouth when we're embryos. This is kind of a little complicated slide, but what it means to say is that that area of the pituitary is formed by a little hand that comes from the roof of the mouth in the embryo, and another one that comes from the brain, and these join hands and they create the pituitary gland. And in between the two, there's a little slit that's called the Rathke's pouch, or the intermediate lobe of the pituitary gland. And again, it doesn't matter what it's called, but it's trapped tissue that can give rise eventually to these tumors that are called craniopharyngiomas. So, and the other question is, so, okay, I have a craniopharyngioma. I've been told I have this tumor. Most people are quite distraught about hearing that they have a brain tumor. Obviously, they hear about people dying from brain tumors. Is this something malignant? Is this something that is going to kill me? Or is it something benign that I don't need to worry about? And the truth is, it's somewhere in between. These are very slowly growing tumors. They usually grow for quite a long time, several months, several years, sometimes, throughout someone's life. But they're more benign in the way they behave. So if someone is able to remove them completely, this can be curable. So these are not tumors that are going to leave that area of the brain and go and metastasize to the bones, to the lungs, to the liver, all these sorts of things. They don't leave that area to go anywhere else. But they tend to grow in these very difficult locations, and that's part of the reason we went over these slides in the beginning. You can see that they're right on top of the pituitary gland, this area that's called the hypothalamus, the vision nerves. They involve some of the major arteries in that area. So they tend to be stuck to many important things. And for this reason, when we attempt to remove them, it may not be feasible to completely remove them. And therefore, if we leave something behind, this can grow back and can cause problems again. Now, one of the major implications of these tumors when they start causing trouble is that they will lead to some sort of hormonal dysfunction, either from the tumor itself or from what we, as a medical community, do to fight them. Because everything we do is a double-edged sword. It does something to the tumor, but in some way it may affect hormonal dysfunction. And again, Dr. Fazeli is going to go in detail. What does that mean? These tumors, there's not that common. Most of the patients that are going to have this, we usually don't know of anyone that has had this tumor. There are about 350 new cases in the US, so that's pretty rare. And they can happen to pretty much anyone. But they usually have two peaks. One is in children, and the other one is in mid to older people, 50 to 75. They do come in two flavors. One is what we call the adamantinomatous craniopharyngioma, and that's the one that usually happens in kids. It's called adamantinomatous because they tend to calcify. They have calcifications in them. They can become almost like a rock. Adamantine is another word for enamel of the teeth. And as we described, these tumors come from tissue that came from the roof of the mouth, and then it usually had all the components to eventually create teeth and all that. So that may not be all that surprising. And they also more likely to have a lot of cysts to them. So it's not just a solid tumor, but they grow as cysts. And these can actually make them a little bit more challenging to treat, the fact that they have all this parts that are really hard like a rock, and they have all this cysts that can invaginate into many important structures. The other flavor, if you want, of craniopharyngioma is what we call a papillary craniopharyngioma. These do not have calcifications. They don't have hardened parts to it. They usually occur in adults as opposed to children. They're less likely to be cystic. But what is also very important is that there are emerging targeted therapies for these tumors that can be treated with medicines. And we'll talk a little bit about that. So someone is diagnosed with a craniopharyngioma. What is the workup that needs to be done before we decide what to do? Typically, they need to have good imaging. Most people would have some form of imaging, whether that's a CAT scan, a CT scan, or an MRI. But not all MRIs and CT scans come the same. There are specialized sequences, what we call KISS sequences and GRE, and a number of other sequences that allow us both to come to an accurate diagnosis, but also to strategize about what's the best way to go around treating this tumor. And the best way to go around treating this tumor may be doing nothing, or maybe exploring some form or potentially of targeted therapy. But it's extremely important in how to plan the surgery. Most patients will need to see a dedicated endocrinologist, neuroendocrinologist, again, such as Dr. Fazeli and many of the group of our fantastic neuroendocrinologists here at the University of Pittsburgh. They need to have a neuro-ophthalmological evaluation with objective testing, visual fields, and optical coherence tomographies, and many of the, again, objective aspects of vision. Most of our patients will also have a neurocognitive evaluation. This will pick up either overt or subtle issues with cognition and memory, and most of the deficits that may come in that area. Obviously, every patient will need to see a neurosurgeon, because a neurosurgeon will likely be the primary person driving the surgery and the surgical treatment. Many times they will see also a Scalbi's ENT surgeon that's going to work with the neurosurgeon. Neuro-oncological evaluation or availability is extremely important as well. Again, there are emerging targeted therapies for these tumors, but also radiation oncology, because forms of radiation are very much in the treatment paradigm of these tumors. So they need to be available and familiar with treating these tumors and have expertise to that. We're lucky to have a fantastic team here in Pittsburgh, with a comprehensive aspect of covering every aspect of treating a craniopharyngioma, and we tend to see a number of these tumors yearly. So having an important, a comprehensive team is extraordinarily important in deciding what to do. And it's important to have every tool in our armamentarium available to us, because not every tumor is treated exactly the same. The experience in the center also plays into understanding what's the best way to treat everyone and choosing the right treatment for every patient. So whether a patient is symptomatic versus asymptomatic, has no symptoms from this tumor, is hugely important. And their age and how sick they are overall is also very important. For example, younger children, when we do surgery to them, we can impact their ability to grow and their ability to go through puberty. So many times we'll change the approach in how we treat this patient population in order to get them through the age that they need their hormones the most. If someone is completely asymptomatic from this, especially if they're older, it may be a tumor that we choose to just observe. And remarkably, these tumors can sit silent and not grow at all for several years. So there's many people in my clinic that I observe, and we get serial imaging. We would get one in 3 months, and then another 6 months, and then a year, and then yearly for a few years. And if the tumor is continuing not to grow, you can space that time frame apart even more. It's also important whether they still have function of their hormones. Many patients would have had treatments before. If they don't have function of their hormones, it makes it much easier to be more comprehensive with the treatment. There's much less to lose. So all these things play into our consideration and how to treat it. The center should be comfortable with a number of the approaches that we use to treat craniopharyngiomas, and we'll speak a little bit more about what those are. But one of the main decision-making points is whether to be comprehensive in treating this tumor. Many times this may mean that we sacrifice the hormonal function. But once we start getting into, our experience has shown that once you start getting into treating craniopharyngioma for a variety of reasons, most of these patients will end up without function. Now, there are a number of patients that we are able to save function, and that's because the way that the tumor is growing allows us to remove the tumor without disrupting any of these functions, and that's very much doable, but not always. And the tumor essentially dictates that. But there are times that you may choose to do a more localized surgery, understanding that you're not going to remove the whole tumor in order to preserve function, and understanding that that will likely mean that some other therapy is going to be needed. Now, when you're treating a patient in that manner, usually something else is going to be needed down the road, whether that's radiation therapy, whether that's repeat surgery, but all of the above, you know, eventually carry also a risk of decreasing function. Radiation therapy has a risk of affecting hormonal function, and certainly the easiest time to remove a tumor is the first time you do surgery. Every second time you go in that area, there's going to be more scarring, less distinct planes, and your ability to be comprehensive with the tumor decreases every time you go back. Other options that are more minimalistic, such as aspiration of the cyst or injection of isotopes that may decrease the growth, are also available. Some of the isotopes are not as available anymore. So it's not always an option. Certainly radiation therapy, either in the form of stereotactic radiosurgery, which is a more focused beam or radiation affecting like smaller parts, or treatments that can happen over several days where weaker beams are given in a broader area, whether that's conventional or proton beam radiation. These are very much an option. And finally, there are targeted therapies, particularly for the papillary craniopharyngiomas that carry certain mutations. This is usually not first-line therapy, and it's reserved for residual or recurrent tumors. But as things are evolving, this may very well become part of the therapy, even as a first-line treatment. Now, in terms of treatment, once we decide to treat a craniopharyngioma, the first line of treatment usually is surgery. And surgery has many flavors. Some of the surgeries are geared towards coming from the side and making what we call a craniotomy, making a window of bone in the skull to gain access to the brain. And that's how we approach approach some of these craniopharyngiomas. These approaches have really been used less and less. Somebody has to be comfortable with them, whether coming from the side, coming from the top of the skull, coming from the front, in between the eyes, and under the frontal lobes, or coming more posteriorly. But the workhorse of treating the craniopharyngiomas has become the endoscopic approaches, endoscopic endonasal approaches, where we use the natural corridors, the natural apertures, and the sinuses with cameras to go back directly to the tumor. And the main advantage of this is not only that you avoid an incision, and nobody wants an incision on their skull, but mainly how we can see everything that we need to see, and having a straight shot at the tumor. You can see how the angle of attack essentially lines up with how a tumor is. So it has many advantages beyond just the cosmetic aspect of it. Harvey Cushing, depicted here on the panel on the left, was the father of American neurosurgery, and he had very good memoirs that remain, and he characterized his tumors as the most challenging tumors in neurosurgery. And that's because, again, they involved many important structures. This one patient that was treated here in 1929, and you see that he had done an incision behind her hairline, and also an incision here. But things have changed dramatically, particularly that because we have developed ways to work together amongst many services in comprehensive centers, and even more so the fact the development of the endoscopes. The endoscopes allow us to take these cameras at the point where we're working, have wider fields of view, and you can see here the schematic where we can go through these dark tunnels that are the nasal sinuses, almost like going through a tunnel. I have here a brief video of the Pittsburgh tunnel, where you're going through the tunnel and then suddenly see this wide, nice view of the city, as opposed to trying to look at the city from the other side of the tunnel. And this allows us to go directly to the tumor and see everything we need to see, particularly the microvasculature, where this connection of the pituitary gland, the little stalk is, which preserve the function. There's been many changes over the years and advancements in these approaches, and we've developed tools that that allows us to go to the majority of places that we need to go in the base of the skull. There are multiple microscopes, endoscopes rather, multiple kinds of cameras, and now we have ultra definition cameras. One of the limitations was how to repair the openings in the base of the skull. And this still remains somewhat of a limitation, but the rates of having fluid leak out the brain because of these openings has decreased dramatically. The reason for this decrease is our ability to use vascularized tissue, use tissue from the patient's own nose to repair defects in the base of the skull in a way that it heals very nicely. Development of instruments, specialized instruments to do fine work in this deep corridor, and understanding more the anatomy of this area plays a huge role in our ability to do this surgery more safely and more effectively. This is one such example of a patient. This is a 67-year-old woman that had significant vision loss that presented to our attention. You see here the tumor starting from right above the pituitary gland, in between that area of the hypothalamus. That's where the tumor is. You see it here lighting up. There's another part of it that is more cystic. That's not a solid part of the tumor, but it also creates mass effect, and that's a part of the tumor that needs to be addressed. So this was we had this sequence here that showed us that the patient's vision nerves and the pituitary gland were apart enough that we could sneak the camera and then go directly to the tumor. So again, that's where specialized imaging and experience come into play. Here is us looking with this camera. This is that little area that is called the pituitary gland. These are the carotid arteries on each side. And then we're opening right above the pituitary gland, right? That's the area where we would attack the tumor. These are the membranes around the brain that are this specific membrane is called the arachnoid. And then you see that those little vessels that surround that area. Now we see here that that stalk, that's the part that connects the pituitary gland with the hypothalamus, is actually pushed to the side. And that's that makes things favorable in us potentially being able to remove the tumor. Now, this very much appears to be an adamantinomatous craniopharyngioma. You see the little specks of calcium. Fortunately, this was not one that is completely calcified, but one of the key aspects of this procedure is finding this, essentially the detachment plane or peel-away plane between the tumor and the surrounding tissues of the hypothalamus. One of the main mistakes that a surgeon can do is actually end up on the wrong plane, because that would affect the little vessels going to the hypothalamus and the pituitary gland. You see again, this connection remains here intact. And once we've detached the tumor, it can slowly be delivered. This is all tumor that has been dissected, so it can be safely extracted. This is the last little piece. That was that cyst that deflated. Again, it's not really attached to anything. We're just removing it gently. And these are the walls of the hypothalamus and that fluid space of the brain that now is free and can flow freely. These are the patient's own tissue that we use, what we call a nasoseptal flap, that covers that area, and because it's alive, it heals nicely and seals that opening. And this patient is a patient that actually were able to preserve her function and then she preserved her hormonal function. For patients that were not able to remove the whole tumor, either because it was stuck to something, whether that's the optic nerve or an artery, this very focused beam irradiation called radiosurgery or stereotactic radiosurgery is a very good option. The way it works for anyone that started fires with a magnifying glass when they were kids, it kind of works the same way. So you take a lot of weak beams or radiation and then focus them in one spot. So that spot would get a multiple of the radiation dose than any of the other tissues that see that one weak beam will get. So that allows us to give doses of radiation that are killing the tumor in deep areas of the brain without actually the brain getting too much radiation. Despite that, if the tumor is very, very close to the optic nerves, that's a limitation for this. And also if the patient has function and the tumor is very, very close to the pituitary gland, that's also a limitation. Other forms of radiation, such as either protobeam or conventional radiation that are fractionated, meaning that instead of like the beams crossing like they are here, but rather like a smaller amount of dose is delivered to a wider area over a period of days. This also can have a risk of decreasing the function of the pituitary, but also carries risks of cognitive dysfunction if the brain gets larger amounts of radiation. We discussed this briefly. Dr. Brastianos was the one that, Dr. Priscilla Brastianos is the bright neuro-oncologist that came up with this. But what she observed was that many of the craniopharyngiomas, particularly the ones that are papillary, carry a specific mutation, this BRAF mutation. And this is a mutation that was acknowledged firstly in melanoma, but other tumors as well. And it's a weak point in the tumor that we can exploit. So medications such as vemurafenib, which is a kinase inhibitor, and also MEK inhibitors can exploit these weak points of the tumors in order to shrink them. Now, these medications are not, they are essentially chemotherapeutic agents. They're targeted therapies, but they can have significant side effects. So for the time being, they're reserved for patients that have residual tumors or that had recurrent tumors that have these mutations. Perhaps in the future, this will be incorporated in a treatment paradigm where a biopsy is done confirming that this particular tumor, or just by statistics, trying this medication because of the high prevalence of these mutations in papillary craniopharyngiomas in order to shrink them so that you can ultimately do surgery. This is not something that is widely available at this point. It is available at our center by one of our neuro-oncologists, but again, is reserved usually at this point for recurrent or residual tumors. Now, adamantinomatous craniopharyngiomas, there are studies ongoing for other targeted therapies, but there's nothing as proven as the papillary craniopharyngiomas. So these are an area of ongoing research. So in a way, this is self-explanatory, but the major threats to the quality of life for a patient with a craniopharyngioma are the threat to the pituitary function, and I'll let Dr. Fazeli elaborate on that, or the hypothalamic dysfunction, which can manifest with obesity, disruption of sleep-wake cycles, having issues with memory or mood. The treatments that we administer, such as radiation therapy, can cause issues. It can affect the ability to think. It can also affect potentially some of the vessels of the brain. And of course, one of the main things that these tumors are associated with are the visual pathways and the possibility of making them worse either with surgery or radiation. So there are many challenging aspects to treating these tumors, which again makes both experience as well as the ability to have a comprehensive center that treats a number of these patients even more important. So I'm gonna switch gears and switch to Dr. Fazeli, and she will speak a little bit more about one of the most common issues with craniopharyngiomas, which are the endocrine effects, either from the tumor itself or from our treatments. Dr. Fazeli.
Thank you so much, George. That was a beautiful introduction. And if you don't mind going to the first slide, please.
Yep.
Great. So as Dr. Zenonos described, craniopharyngiomas can affect pituitary function or also the function of the hypothalamus. So as he described, the hypothalamus sits above the pituitary gland and is connected to the pituitary gland by a stalk. And hormonal signals travel from the hypothalamus through the stalk to the pituitary gland and signal the pituitary gland to make hormones. In turn, the pituitary gland, which we often refer to as the master gland, acts like a master control center. It sends hormonal signals to other glands in the body to make or release hormones. For example, as you can see here, the pituitary makes ACTH, which signals the adrenal glands to make cortisol. The pituitary also makes TSH, which thyroid stimulating hormone, which signals the thyroid gland to make thyroid hormone. FSH and LH are two other pituitary hormones that signal the ovary and the testes. So in women, FSH and LH are necessary for a normal menstrual cycle, and in men, normal FSH and LH signaling are necessary to make testosterone and sperm. The pituitary gland also makes prolactin, which is a hormone which typically increases during pregnancy, and that's important for breast milk production in nursing women. And the last hormone that the anterior pituitary makes is growth hormone. Now, the posterior pituitary gland makes additional hormones, and one of those hormones is vasopressin, which is also called antidiuretic hormone. So what vasopressin does is it helps us hold on to water. And therefore, if you're not making enough vasopressin or antidiuretic hormone, you urinate out everything that you drink. And as you can imagine, that can be very disruptive to sleep, and it can make it difficult to work, and therefore it significantly affects quality of life. So the production of all these hormones, whether anterior or posterior pituitary, can be significantly disrupted by either the craniopharyngioma itself or its treatment. Next slide, please. So as I mentioned, one of the hormones made by the pituitary gland is ACTH, and ACTH stimulates the adrenal gland to make cortisol. Next. So therefore, disruption of ACTH production will lead to adrenal insufficiency or low cortisol levels. And symptoms of adrenal insufficiency or lack of cortisol production include fatigue, loss of appetite, nausea, vomiting, diarrhea, weight loss. And importantly, it can be very life-threatening if it's untreated. So therefore, it's very, very important that adrenal insufficiency be evaluated for and also treated. Next. So another hormone made by the pituitary gland is thyroid stimulating hormone, and thyroid stimulating hormone signals the thyroid gland to make thyroid hormone. Next. So disruption of TSH production will lead to hypothyroidism, and low thyroid hormone levels can lead to fatigue, dry skin, dry hair, constipation, anemia, which can also contribute to fatigue. Now, importantly, the most common cause of hypothyroidism is a thyroid gland that is not functioning properly. And those low thyroid hormone levels send back a signal to the pituitary gland, which leads to an increase in TSH levels. So these high TSH levels are trying their hardest to make the thyroid gland work, but it's just not responding. So therefore, when a primary care doctor is screening a patient for hypothyroidism, he or she will check a TSH level, and in the vast majority of cases of hypothyroidism, the TSH level will be high. But in this very special case, the TSH level will not be high because the problem isn't the thyroid gland itself, but it's instead the signal is broken between the pituitary and the thyroid. So really what's going on is the pituitary gland is not sending out the proper TSH signal, and so therefore it's very likely that in this setting, the TSH level will be normal or even low. So therefore, it's really important that patients be evaluated for hypothyroidism by a pituitary specialist, because if only a TSH level is checked, the diagnosis of hypothyroidism could be missed entirely. Next. So other hormones made by the pituitary gland include FSH and LH. Next. So disruption of these hormones lead to low levels of estrogen and testosterone. And signs and symptoms of estrogen and testosterone deficiency include fatigue, decreased muscle mass, low libido, and decreased bone density. I will just point out that it's important to note that all individuals with hypogonadism will not necessarily be treated or need treatment because, for example, postmenopausal women have low estrogen levels because of menopause anyway, and we typically don't at this moment in time replace estrogen in this population, but it's very important for this to be evaluated for. Next. So another pituitary hormone is prolactin. And again, prolactin is important for breast milk production in nursing women. Now, prolactin production is controlled by dopamine, which is made in the hypothalamus, which again is that gland that sits above the pituitary gland and is connected to the pituitary gland by a stalk. The hypothalamus makes dopamine, and dopamine travels through the stalk and inhibits or suppresses prolactin secretion. So therefore, anything that interferes with the ability of dopamine to travel through the stalk and into the pituitary will cause a high prolactin level. Next. So here on the left, you can see a patient with a craniopharyngioma, and you can see that it's interfering with the stalk that's connecting the pituitary and the hypothalamus. And the resulting high prolactin levels lead to disruption of another hormone made in the hypothalamus, which is the hormone that signals the pituitary gland to make FSH and LH. So therefore, a high prolactin level is another cause of low estrogen and testosterone levels, or hypogonadism. Next. Great. So the pituitary gland also makes growth hormone, which signals the liver to make IGF-1. Next. And IGF-1 is responsible for most of growth hormone's growth promoting effects. Disruption of growth hormone production by the pituitary gland leads to growth hormone deficiency. And the signs and symptoms of growth hormone deficiency include fatigue, a decrease in bone density, and a decrease in muscle mass. Next. Now, all of the hormones I've discussed so far are made by the anterior pituitary. The posterior pituitary, which you can see here, is the bright spot on the sagittal or sideways MRI image, makes the hormone called vasopressin or antidiuretic hormone, or ADH. An antidiuretic hormone, again, is that hormone that helps us hold on to water. So therefore, if you're not making antidiuretic hormone, you urinate out everything that you drink. And many individuals with craniopharyngiomas will have AVP deficiency, or what we call diabetes insipidus. And they'll have it either at the time of diagnosis or potentially as a result of treatment. And importantly, we can treat this with desmopressin, which is a vasopressin-like or antidiuretic hormone-like substance. But when this becomes challenging is if there's also involvement of the hypothalamus. And as you may remember, Dr. Zenonos explained that craniopharyngiomas can also affect the hypothalamus. And that's because the hypothalamus controls whether or not we can sense thirst. So usually if you're urinating out a lot of fluid, that leads to your sodium level going up or increasing to above the normal range, and you become very, very thirsty thanks to the hypothalamus and drink fluids. And therefore, usually AVP deficiency or diabetes insipidus is really a significant detriment to quality of life. But usually the patient can keep their sodium level in the normal range, and we can treat this very easily and significantly improve quality of life with the desmopressin. But if the hypothalamus isn't working properly and you're not sensing thirst, this can be very, very challenging because that usually requires frequent sodium monitoring and a specific fluid prescription in addition to treatment with desmopressin, because the patient is not realizing that their sodium level is rising. Next. So you can therefore see that there are many hormones that can be affected by a craniopharyngioma, but we can typically easily replace them and significantly improve symptoms and quality of life. Next. So one last thing I wanted to discuss is weight gain, which unfortunately is a common finding in patients with craniopharyngiomas or individuals who've been treated for craniopharyngiomas. We think the weight gain is due to hypothalamic involvement, as the hypothalamus not only sends hormonal signals to the pituitary gland, not only helps us sense thirst, but also regulates important processes such as appetite. In patients with craniopharyngiomas, a decrease in energy expenditure has been noted, also probably due to hypothalamic involvement. And this means that the number of calories burned per day is lower or decreased. And this is likely both due to decreased resting energy expenditure, but there have also been studies using activity monitors like a Fitbit, and those have reported a decrease in activity levels. Hyperphagia or increased hunger is another possible reason for weight gain, again, probably due to hypothalamic effects. But I will say that most of the patients that I see report that they're not really eating more per day than before, but are gaining weight. And therefore, I think much of the weight gain may be due to this decreased energy expenditure, because even if you're eating the same number of calories in a day, if you're burning fewer calories, you'll gain weight. And lastly, it's really, really important for us to get the hormone replacement right, because both over and under correction of pituitary hormones can both lead to weight gain. Thank you.
Thank you, Dr. Fauci. It's a beautiful presentation and examples of what exactly happens. And again, this can be a result of the tumors themselves, but it can be also the result of all the treatments we do, whether this is related to surgery or radiation therapy. A balance and a decision making in terms of what exactly to do. It's a very nuanced aspect of treating a craniopharyngioma, and the specifics of each patient themselves, their age, their comorbidities, their status in terms of the function of the gland, but also their logistical issues and social surroundings and context. They all play into the decision making. So it's something that it requires a lot of discussion. So in conclusion, craniopharyngioma remains a difficult disease to treat still. There's been significant improvements in treating craniopharyngioma, and we've made significant leaps in the outcomes, but it does require still specialized care in comprehensive centers to be able to have all the options available. And thankfully, there's continued research in improving the outcomes and quality of life in patients with craniopharyngioma. Hopefully, some of the targeted therapies will be available soon, both for papillary craniopharyngioma that are available already, but perhaps with a better side effect profile, but also perhaps for some of the adenomatinomas as well. and then there are active research efforts that are ongoing as we speak. So with that, we'll conclude, and we'll of course both take any questions if anyone had any.
Thank you so much. That was a great presentation. We do have a couple questions that came through. The first one is, if pituitary gland has to be completely removed during surgery, how does that impact the patient's quality of life and life expectancy?
Dr. Fazla, you want to tackle that one?
Absolutely. So I think that's a really important and a very important question. And I think we are pretty good at replacing pituitary hormone deficiencies, but we're not. But the human body is much better than we are. So we can do a very good job of replacing adrenal hormones, thyroid hormone. And in younger individuals, sex hormones. In males, we can replace testosterone. We can replace the antidiuretic hormone with desmopressin, but it is a significant burden on the patient because they really have to become their pituitary gland. So I will say that the patients that I see are masters at it, and once we start growth hormone, which is something we didn't used to do before because we didn't fully understand what the potential effects of growth hormone would be on craniopharyngiomas, but now we know that it can be safe to give patients or replace growth hormone. I think that quality of life improves significantly, and as long as the patient is involved and very proactive, I think that quality of life can be very, very good for those patients.
I think there's a part of the question that asked about the overall prognosis and the span of life, the lifespan, I guess. Was that part of it?
Life expectancy, yes.
Yeah.
And they actually had a follow-up. What kind of follow-up endocrine monitoring is required if you have pituitary gland removed?
Yeah, so we follow patients with pituitary hormone insufficiency very, very closely. I would say in the post-operative period, we see them about a month after their surgery, but in the interim, we are checking hormone levels, titrating the dose of desmopressin as necessary, and then see them again 3 months after surgery, 6 months after surgery. And once the patient becomes more comfortable with managing their pituitary hormone insufficiency, now, they're patients that I see once a year because they are doing very, very well managing the pituitary hormone insufficiency on their own once we've titrated the doses of the hormones appropriately. Great question.
Okay, thank you. The next question is kind of a 3-part question, so I will read the backstory and then do the first question, let you answer, and then the second and the third. It says, 27 years ago at age 34, I was diagnosed with craniopharyngioma. I had a craniotomy at 25 years ago, followed by multiple transsphenoidal surgeries, gamma knife radiation, and a P32 injection. Thankfully, it has been 12 years since my last recurrence. The recurring remnants always seemed both cystic and solid. My initial tumor was basically optic chiasm, and so post-operatively, I had bilateral hemianopsia. I recently developed torsional seesaw nystagmus, which combined with my visual field defects makes reading very difficult. It is believed that the nystagmus most likely is the result of multiple surgeries and radiation to the optic nerves. And the first question is, have you ever had any experience with nystagmus in your craniopharyngioma patients?
The nystagmus can be multifactorial. Seesaw nystagmus in particular, but it would be hard to know exactly why this developed without seeing some of the imaging and understanding if there's any other implications. Occasionally, there's effects on the microvasculature. either in the area of the optic nerves, but also in other areas as well of the brain that can be relevant to developing nystagmus or developing any other visual abnormalities that are not related necessarily to the optic nerve itself. So I think this will likely need evaluation by a neuro-ophthalmologist. I believe you may have had evaluations by neuro-ophthalmologists before, whether there's any component of it that is reversible. I suspect that, unfortunately, it's probably not going to be, but it's very hard to know without seeing any of the imaging and see if there's anything at this point that may be compressive. It does sound like you had a craniopharyngioma that was partly cystic, and the cysts can eventually grow, and occasionally in multiple recurrent tumors, especially if the solid components are stable, can be addressed in a more targeted fashion if the tumor is not thought to be curable. So again, there's a lot of nuances in terms of treating patients with craniopharyngiomas, especially the multiple recurrent ones, and each patient is a little bit different. We would of course be happy to review everything in more detail. We do have a in our center, we have an option for patients to send films that is free. There's no cost to anyone, and we'd be happy to review them and see if there's anything that could be done.
Okay, thank you. And then her next question was, what has been your experience with adults and recurrence? How long have you seen patients go without recurrence? I have been getting MRIs yearly and wonder if that may always be the case.
That's a great question. You know, the recurrences do vary, and these are generally slow-growing tumors. For patients that have received radiation, and it seems that you had stereotactic radiosurgery, the MRI will never be normal necessarily, so the tumor doesn't always shrink away to the point where you get a normal MRI. As a matter of fact, particularly with someone that had multiple surgeries, the MRI is never going to be normal. And so continued observation for this tumor is going to be required. Now, the longer that you observe a tumor and they don't change, then you feel comfortable spacing the time frames apart even more, to a point where you may be seeing patients every 2, 3, or even 5 years, if there's been like a period of time that they haven't changed at all. But being vigilant about recurrence, I think it's for someone that has a multiple recurrent craniopharyngioma, I think that the realistic aspect of it is that someone is going to need lifelong surveillance for it, regardless of the time that it's going to be between each time that it's been looked at.
Okay, thank you. And the final part of her question was, I have had multiple major stresses in my life recently and have found it harder for me to rebound the day after any kind of stress. I worry how I will be able to deal with my adrenal insufficiency as I get older and the world gets crazier. Do you ever have to increase the daily dose?
So that's a great question. I would say that it sounds like you're an expert at managing your adrenal insufficiency if you realize that increasing the dose is the way to respond to the increased stressors. We try not to increase the daily dose because we've learned over the years that we've probably been over treating adrenal insufficiency, and slowly over the last number of years, the dose that we consider physiologic replacement for adrenal insufficiency has gotten lower and lower and lower. And that reminds me that I forgot to answer the question about life expectancy. With normal hormone replacement, we expect life expectancy to be the same as you would expect a normal life expectancy. So, you know, things like giving somebody too much hydrocortisone or prednisone, over treating the adrenal insufficiency, could lead to detrimental effects in terms of metabolic disorders, loss of bone mass. So we try not to do that, but really the patients are the experts at this, and they know what they need in order to manage stressful situations. And so I always defer to the patient in the setting of physiologic stress or other stressors.
Okay, thank you. And then we have one more question and a comment. The comment is just to say that the video removing the tumor is amazing. And then the last question is, I had my first craniopharyngioma at 3 years. It was removed with surgery and radiation. Another tumor was discovered when I was 29 and gamma knife was used. A third tumor was just discovered. Am I going to have these the rest of my life?
I guess the question here is whether we're referring to a recurrence or a completely new tumor. I suspect what we're discussing about here is recurrences. I don't think we're discussing that there's a new craniopharyngioma that formed, but rather there's a recurrence of the craniopharyngioma. And unfortunately, these tumors do recur, and they do require treating them in a way, crossing every bridge every time as it comes. It's a little bit difficult to know the specifics without, again, reviewing the imaging. And again, we'll be happy to review, without a cost about, if that's something that you wished. But I suspect that this is a craniopharyngioma that, for some reason, there's some component of it that is likely difficult to access. It may be, on the optic nerve or some of the microvasculature or the arteries that led the surgeons not to be able to remove it. So it will likely require observation and monitoring for the years to come. And again, as with the prior person who was asking some questions, the longer that the patient goes without a recurrence, the longer that you feel comfortable spacing this imaging apart. I'm sorry that you had to deal with this since the age of 3. I understand that this has been very tough, and you would want to separate yourself from the disease itself. The flip side of that, it sounds that you're doing quite well, and that you've been fighting this bravely for so many years. So there's no reason not to do that for the remainder to come.
Thank you so much. That was a great presentation. We really appreciate both of you coming out today and just teaching us so much. Again, if anybody else has any questions, feel free to reach out directly to the doctors, or you can email us and we will also reach out for you. And that will conclude today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org after it is edited. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. And again, thank you for joining us, and enjoy the rest of your day. Thank you again.
Thank you very much for the opportunity. Thank you, Pranay.
Thank you.
Have a good night.